5 essential vitamins for kidney health after age 60. Thus, introduction. Welcome. Today, we embark on an important journey into the health of our kidneys, particularly as we navigate life beyond the age of 60. It's a time when our bodies naturally undergo changes, and the kidneys, those remarkable organs responsible for filtering our blood and maintaining balance within us, are no exception. We need to acknowledge the physiological reality that kidney function often tends to decline with age. The efficiency measure we use, known as the glomerular filtration rate or GFR, typically decreases over the years. Along with this, the kidneys may become less effective at concentrating urine, clearing metabolic waste, and precisely managing the electrolytes vital for our health. Subtle structural changes also occur within the kidney tissue itself, involving gradual scarring and shrinkage of the functional units. This age-related decline isn't just a passive part of getting older, it significantly increases our susceptibility to chronic kidney disease, or CKD. Medical statistics consistently show that CKD is far more prevalent in individuals over 65 compared to younger groups. And CKD is much more than just a kidney issue. It can lead to symptoms that deeply impact daily life. Think persistent fatigue, swelling or edema, anemia resulting from low red blood cell counts, and often debilitating bone problems. Even more critically, CKD stands as a major independent risk factor for serious cardiovascular events like heart attacks, heart failure, and stroke, and it markedly increases the risk of overall mortality. The connection between the health of our kidneys and the health of our heart and blood vessels is profound and undeniable. In the crucial effort to preserve kidney function during these later stages of life, nutrition plays a pivotal role. A growing body of scientific research offers compelling evidence that certain specific vitamins are uniquely vital. Now, these micronutrients aren't magic bullets, but they act as essential co-factors and regulators. They can help support the kidney function we still have, potentially slow down further decline, and very importantly, assist in managing the dangerous complications that often accompany CKD in older adults. In this discussion, we will delve into an analysis firmly rooted in scientific and medical understanding of 5 vitamins considered particularly essential for kidney health after 60. However, it is absolutely crucial to emphasize from the outset that approaching any vitamin supplementation must be done with extreme caution and always under the guidance of qualified healthcare professionals. Please remember, the information provided here is for educational purposes and should never replace professional medical advice. Explanation: why vitamins are critical for aging kidneys. So, why exactly are vitamins so critical for our kidneys as they age? Let's explore the underlying reasons. First, we need to understand the aging kidney itself. The kidneys are not immune to the passage of time. On a microscopic level, significant changes accumulate, often without us noticing. The glomeruli, those tiny, intricate filtering units, can undergo a process called glomerulosclerosis, essentially hardening and scarring, which directly impairs their ability to filter blood effectively. The renal tubules, the long, winding tubes responsible for reabsorbing vital substances back into the bloodstream and secreting waste products into the urine, can experience tubular atrophy, meaning they shrink and lose their functional capacity. The surrounding tissue, known as the interstitium, often develops fibrosis or scarring, which further compromises the kidney's structure and function. Furthermore, the small blood vessels within the kidneys frequently thicken and stiffen. Taken together, these structural changes lead to a gradual loss of nephrons, the fundamental working units of the kidney. It's estimated that after the age of 40, our GFR typically declines by about 1 milliliter per minute each year, and this rate can unfortunately accelerate if we have underlying conditions like high blood pressure or diabetes. Beyond just the decline in filtration rate, the functional abilities of the renal tubules also diminish. The aging kidney becomes less responsive and less flexible in regulating the body's water and sodium balance. This reduced adaptability makes older adults more vulnerable to dehydration, especially during hot weather or illness. Conversely, it also makes them more prone to fluid overload and swelling if fluid intake becomes excessive. The kidney's capacity to excrete acid waste products and reabsorb bicarbonate, which helps maintain the body's proper pH balance, also decreases. This increases the risk of metabolic acidosis, a state where the body becomes too acidic. Equally important are the kidney's endocrine functions, its role in producing hormones. Healthy kidneys produce erythropoietin, or EPO, a hormone absolutely essential for stimulating the bone marrow to produce red blood cells. They are also the primary site where inactive vitamin D is converted into its biologically active form, calcitriol. As kidney function declines, both EPO production and vitamin D activation falter. This directly contributes to two very common and impactful problems seen in older adults with kidney issues: anemia and active vitamin D deficiency. Furthermore, the aging kidney becomes more fragile, possessing less physiological reserve than its younger counterpart. It's more easily injured by various insults, things like uncontrolled high blood pressure, persistently high blood sugar levels in diabetes, the toxic effects of certain medications, see especially common pain relievers known as NSAIDs, like ibuprofen and naproxen, some antibiotics, and contrast dyes used in medical imaging, or even episodes of severe dehydration. Following an injury, the kidney's ability to repair itself and recover function is also significantly slower and less complete compared to younger kidneys. Now, let's connect this to vitamins. The relationship between vitamins and kidney health is complex and deeply intertwined with how the kidneys work. One major role of vitamins, especially the B-complex vitamins that includes B1, B2, B3, B5, B6, B7, B9, and B12, is to act as indispensable coenzymes. Think of coenzymes as essential helper molecules required for hundreds of enzymes to carry out their specific biochemical reactions. Our kidneys are metabolic powerhouses, constantly engaged in filtering blood, reabsorbing vital nutrients, and excreting waste. This high level of metabolic activity demands incredibly efficient enzymatic processes. B vitamins are critical for energy production, for processing proteins and amino acids, and for building and repairing cells. Deficiencies in these B vitamins can disrupt these fundamental pathways, potentially impairing the function of kidney cells and overall kidney performance. A classic example involves the synergy between vitamins B6, B9s, which we also know as folate, and B12. These three work together in the metabolism of an amino acid called homocysteine. When homocysteine isn't properly metabolized, it builds up to high levels in the blood, a condition called hyperhomocysteinemia. High homocysteine acts as a potent toxin to blood vessels, promoting dysfunction, oxidative stress, inflammation, and increasing the tendency for blood clots. This significantly contributes to the accelerated hardening of the arteries, known as atherosclerosis, and the tragically high risk of heart attacks and strokes seen in patients with chronic kidney disease. Another vital connection involves antioxidant defense and inflammation regulation. Both the natural aging process and chronic kidney disease are characterized by increased oxidative stress. This is essentially an imbalance where damaging molecules called free radicals overwhelm the body's natural antioxidant defenses. Simultaneously, there's often a state of chronic, low-grade inflammation simmering throughout the body. These intertwined processes inflict damage on delicate kidney cells, promote scarring or fibrosis, and accelerate the progression of kidney disease. Certain vitamins, like vitamin C and vitamin E, have direct antioxidant properties, meaning they can neutralize free radicals. Others, such as vitamin D and potentially vitamin B6, play crucial roles in modulating the immune system and inflammatory responses. They can influence the production of inflammatory chemical messengers and help regulate immune cell activity, potentially dampening down that chronic inflammation, both within the kidney and systemically. Perhaps one of the most complex and critical areas where vitamins intersect with kidney function is in regulating mineral metabolism and bone health. This is often referred to as the CKD mineral and bone disorder, or CKD-MBD axis. The kidneys are the master regulators of mineral balance, meticulously controlling the levels of calcium, phosphorus, and magnesium in our bodies. As we mentioned, they produce calcitriol, the active form of vitamin D. Calcitriol works hand in hand with parathyroid hormone, or PTH, which is secreted by the small parathyroid glands in the neck. Together, they control how much calcium and phosphorus we absorb from our food and regulate the release of calcium from our bones. Now, another key player here is vitamin K2, which we'll discuss in more detail later. It plays a crucial role in directing calcium to the right places. When kidney function declines, this entire intricate system breaks down. Reduced calcitriol production leads to less calcium absorption, causing blood calcium levels to drop. This drop triggers the parathyroid glands to dramatically increase their production of PTH, leading to a condition called secondary hyperparathyroidism. These persistently high PTH levels cause calcium and phosphorus to be leached out of the bones, leading to a spectrum of bone diseases known as renal osteodystrophy, making bones weak and prone to fracture. It also contributes to high phosphorus levels in the blood. This disturbed mineral balance is a major driver of vascular calcification, the dangerous buildup of calcium deposits within the walls of our blood vessels. This calcification makes arteries stiff, raises blood pressure, impairs blood flow, and is strongly linked to heart attacks, strokes, and death in CKD patients. Therefore, ensuring adequate status and appropriate modulation of vitamin D and vitamin K2, always under strict medical supervision, are absolutely fundamental components of managing this complex CKD-MBD. Finally, vitamins provide crucial support for hematopoiesis, the process of blood cell formation. Anemia, or low red blood cell count, is an extremely common and debilitating complication of CKD, primarily because the failing kidneys produce less of the hormone EPO. However, making healthy red blood cells requires more than just EPO and iron. Vitamin B12 and vitamin B9's folate are absolutely essential for the proper maturation of red blood cells as they develop in the bone marrow. A deficiency in either B12 or folate leads to a specific type of anemia called megaloblastic anemia, where the red blood cells are abnormally large and immature. This can significantly worsen the overall anemia experienced by CKD patients. Vitamin B6 also plays a supporting role, being necessary for the synthesis of heme, the iron-containing part of hemoglobin. So, it becomes clear that vitamins are deeply involved in many aspects of kidney function and overall health. Unfortunately, older adults, especially those with kidney disease, face a heightened risk of developing deficiencies in these crucial vitamins. Several factors contribute to this increased risk. Impaired absorption is a common issue. The natural aging of our digestive system can reduce nutrient uptake. A condition called atrophic gastritis, involving inflammation and thinning of the stomach lining, is quite common in the elderly and significantly impairs the secretion of stomach acid and a substance called intrinsic factor, both of which are necessary for absorbing vitamin B12. Other gastrointestinal diseases can also interfere with the absorption of various vitamins. Furthermore, the restrictive diets often necessary for managing CKD can inadvertently lead to lower vitamin intake. To control the disease, patients are often advised to limit their intake of protein, potassium, phosphorus, and sodium. While essential for kidney health, these restrictions can mean cutting back on foods that are rich sources of vitamins. For instance, limiting red meat might reduce B12 and B6 intake. Restricting certain fruits and vegetables high in potassium could lower folate intake, and limiting dairy products, often due to their phosphorus content, reduces sources of calcium and fortified vitamin D. Increased requirements or losses also play a role. The chronic inflammation and oxidative stress that accompanies CKD might actually increase the body's demand for certain antioxidant vitamins and those involved in metabolic repair processes. Critically, for patients undergoing dialysis, whether hemodialysis or peritoneal dialysis, significant amounts of water, soluble vitamins like the B vitamins and vitamin C, are lost across the dialysis membrane during each treatment session. This necessitates routine supplementation for these individuals. The reduced kidney function itself is a direct cause of some deficiencies. As we've emphasized, the kidney's declining ability to activate vitamin D is a direct consequence of a falling GFR. Impaired kidney function can also affect how other vitamins are reabsorbed or excreted by the body. Finally, the presence of other chronic conditions, or comorbidities, and the use of multiple medications, known as polypharmacy, add to the risk. Older adults frequently have conditions like diabetes, hypertension, and heart disease alongside kidney disease, and they often take numerous medications. Several common drugs can interfere with vitamin status. For example, metformin, a widely used diabetes medication, and acid-suppressing drugs like proton pump inhibitors, PPIs or H2 blockers, used for heartburn or ulcers, are well known to impair vitamin B12 absorption. Certain diuretics, often used for blood pressure or fluid control, can increase the loss of water, soluble vitamins through urine. Understanding this complex web of factors underscores why it's so important to assess vitamin status and ensure adequate intake of essential micronutrients, particularly for the 5 vitamins we are about to discuss in detail, which play especially pivotal roles in maintaining kidney health and mitigating complications in this vulnerable older population. Top 5 essential vitamins for kidneys after age 60. Let's focus on the top 5 vitamins considered most essential for kidney health after the age of 60, examining the scientific basis for their importance. Subsection 3.A. Vitamin D. First on our list is vitamin D. Often associated primarily with bone health, vitamin D's significance for the kidneys is profound. The form that actually exerts effects in the body, known as calcitriol, isn't just a vitamin, it's a potent steroid hormone. And crucially, its final activation step happens primarily within the kidney's tubules, thanks to an enzyme called 1-alpha hydroxylase. Calcitriol is the master regulator of calcium and phosphorus homeostasis. It boosts the absorption of these minerals from the food we eat and works closely with parathyroid hormone, or PTH, to keep our blood calcium levels stable. When kidney function declines, the activity of that crucial kidney enzyme, 1-alpha hydroxylase, decreases. This leads to less calcitriol being produced. The consequences are reduced calcium absorption, low blood calcium levels, and a resulting surge in PTH secretion from the parathyroid glands, the condition known as secondary hyperparathyroidism. This hormonal imbalance is the starting point for the cascade of problems collectively called CKD, mineral and bone disorder, or CKD-MBD. So how does vitamin D help protect the kidneys and control these complications? Its mechanisms are multifaceted. Firstly, by improving calcium absorption and directly suppressing the production of PTH in the parathyroid glands, active vitamin D, or the therapeutic analogs used by doctors, helps bring secondary hyperparathyroidism under control. This is vital for preventing excessive bone breakdown and managing high phosphorus levels. It also interacts with another hormone involved in phosphorus balance called FGF23, although this relationship is intricate. Appropriate vitamin D therapy, always guided by a doctor, is therefore a fundamental part of managing CKD-MBD. But the influence of vitamin D extends beyond mineral metabolism. Receptors for vitamin D, called VDRs, are found in many different cell types throughout the body, not just in bone and intestines. They're present in immune cells, heart muscle cells, the endothelial cells lining our blood vessels, and importantly, in various kidney cells, including the filtering podocytes and tubular cells. Activating these VDRs in different tissues may offer several benefits relevant to kidney disease. For instance, research, primarily from experimental models, strongly suggests that vitamin D can help suppress the renin-angiotensin-aldosterone system, or RAS. This system plays a major role in regulating blood pressure, but when it's overactive, it significantly contributes to kidney damage through inflammation and fibrosis. By potentially dampening RAS activity, vitamin D might contribute to better blood pressure control and reduce kidney injury. Furthermore, vitamin D has known immunomodulatory properties. It can help reduce the production of pro-inflammatory signals while promoting anti-inflammatory ones. It might also slow down the process of kidney scarring or fibrosis. Additionally, some clinical studies, particularly those using specific vitamin D activating drugs, have shown a potential to reduce proteinuria, which is the presence of excess protein in the urine, a key sign of kidney damage and a strong predictor of worsening kidney function and cardiovascular problems. What does the broader scientific evidence tell us? Numerous large observational studies, like the extensive NS surveys in the US, have consistently found a strong link between lower blood levels of vitamin D1000 measured as 25-hydroxyvitamin D or 25-OHD and a higher risk of developing CKD. Lower levels are also associated with faster disease progression, increased proteinuria, and higher mortality rates, both in the general population and specifically in patients with CKD. When we look at intervention trials, randomized controlled studies supplementing patients with non-dialysis CKD using nutritional forms of vitamin D like D2 or D3 have clearly shown they can effectively raise blood levels and help control PTH. However, the evidence regarding whether this supplementation consistently slows down the decline in kidney function, GFR, or significantly reduces major heart attacks or strokes has been less conclusive and requires more large-scale research. On the other hand, trials using active vitamin D's calcitriol or specific vitamin D activating drugs like paracalcitrol to manage established CKD-MBD in patients with late stage kidney disease or those on dialysis have proven effective in controlling PTH levels. Some of these trials also suggest potential benefits in reducing proteinuria and possibly improving survival, although definitive proof for these harder endpoints is still being gathered. Why is vitamin D deficiency so rampant in this population? Several factors converge. Older adults naturally synthesize less vitamin D in their skin upon sun exposure, and their skin itself may be less efficient at this process. Lifestyle factors often mean less time spent outdoors. Dietary intake is often insufficient, as few foods are naturally rich in vitamin D, and kidney diets might restrict fortified sources like dairy. Intestinal absorption might also decrease with age, but critically for CKD patients, the declining kidney function directly impairs that final, essential activation step, converting vitamin D to calcitriol. As a result, deficiency, often defined as blood levels below 20 or 30 nanograms per milliliter, is extremely common in CKD stages 3 to 5, potentially affecting a staggering 70 to 90% of these individuals. Where do we get vitamin D? Natural food sources include fatty fish like salmon, mackerel, and herring, cod liver oil, egg yolks, and mushrooms exposed to UV light. Many foods are fortified, including milk, some yogurts, cereals, and juices, but always check labels, especially if you need to monitor phosphorus or potassium intake due to kidney restrictions. Sunlight exposure is a major natural source, but achieving adequate levels safely can be challenging, especially for older adults or those with limited mobility. Now, here comes an absolutely crucial warning regarding vitamin D. Supplementation with any form, whether it's the nutritional forms D2 or D3, or the active forms like calcitriol, or its analogs, must, without exception, be initiated and closely monitored by a physician. The decision on which type and dose to use depends entirely on blood test results, including vitamin D levels, calcium, phosphorus, and PTH, as well as the specific stage of kidney disease. The goal is to achieve sufficient vitamin D levels and control PTH within the target range appropriate for the CKD stage, while strictly avoiding high calcium or high phosphorus levels in the blood. Unsupervised, high-dose vitamin D intake is dangerous. It can lead to toxicity, causing high blood calcium, kidney stones, and harmful calcium deposits in soft tissues like blood vessels, the heart, lungs, and even the kidneys themselves, potentially worsening kidney function. Medical guidance is not just recommended, it is essential for safety. Subsection 3b Vitamin B6. Moving on, our second essential vitamin is vitamin B6, also known as pyridoxine. This is a water-soluble vitamin, and its main active form in the body is called pyridoxal 5-phosphate, or PLP. Think of PLP as a critical helper molecule, a coenzyme, essential for over 100 different enzymatic reactions in our bodies. A large proportion of these reactions involve the metabolism of amino acids, the building blocks of proteins. How does vitamin B6 relate specifically to kidney health and managing complications? One of its most important roles is in the metabolism of homocysteine. As we touched upon earlier, high levels of homocysteine are toxic to blood vessels and are a major risk factor for heart disease, especially in people with CKD. Vitamin B6, specifically the active PLP form, acts as a coenzyme for two key enzymes that help convert homocysteine into a different, harmless amino acid called cysteine. If there isn't enough active vitamin B6, this conversion pathway slows down, leading to a buildup of homocysteine. Another potential benefit of vitamin B6 relates to something called advanced glycation end products, or AGEs. These are harmful compounds that form when sugars react with proteins or fats in our bodies. AGEs accumulate excessively in people with diabetes and also in those with kidney disease, and they contribute to damage in blood vessels, nerves, and the kidneys themselves. Some research, particularly looking at a specific form of B6 called pyridoxamine, suggests it might help inhibit the formation of these damaging AGEs by trapping some of their precursors. Vitamin B6 also plays a role in immune function and inflammation. The active form, PLP, is needed for making certain neurotransmitters and for the proper function of our immune cells. Some studies have linked low vitamin B6 status to markers of chronic inflammation, which, as we know, is a common feature of both aging and CKD. Finally, vitamin B6 has a role, albeit a supporting one, in hemoglobin synthesis, the process of making the protein in red blood cells that carries oxygen. PLP is involved in one of the steps to create heme, the iron-containing part of hemoglobin, While less common than anemia caused by lack of iron or EPO, a severe deficiency in B6 could potentially contribute to anemia. What's the scientific backing for these roles? Studies consistently show that patients with CKD, particularly those undergoing dialysis, tend to have lower levels of the active form of B6, PLP, in their blood and higher levels of homocysteine compared to healthy individuals. Clinical trials that gave patients a combination of B vitamins, including B6, B9s of folate, and B12, did successfully lower homocysteine levels. However, the results from large trials designed to see if this homocysteine lowering actually translated into fewer heart attacks or strokes in high-risk patients, including those with CKD, have been largely disappointing or inconsistent. This might mean that either the vascular damage in advanced kidney disease is too far gone to be reversed simply by lowering homocysteine, or that high homocysteine is more of a marker of underlying problems, rather than a direct cause that we can easily fix with vitamins alone in this population. Research into the AGE inhibiting potential of pyridoxamin showed some early promise in diabetic kidney disease, suggesting it might slow progression, but larger, more definitive trials are still needed. Why might people with CKD be low in B6? Besides potentially getting less from their diet, especially if restricting protein, patients lose significant amounts of this water-soluble vitamin during dialysis treatments. The uremic environment itself, the buildup of waste products in the blood along with chronic inflammation, might also interfere with how B6 is metabolized or increase how quickly it's broken down, leading to a sort of functional deficiency, even if blood levels don't seem dramatically low. Certain medications can also interfere with B6. Where do we find vitamin B6 naturally? Good food sources include poultry, fish, organ meats like liver, potatoes, fortified cereals, legumes like beans and lentils, and bananas. Now, a crucial warning regarding supplementation. Adding extra vitamin B6 should ideally be guided by a doctor's assessment and possibly lab tests. For dialysis patients, B6 is routinely included in special kidney vitamin formulas designed to replace what's lost during treatment. Typical supplemental doses, perhaps in the range of 10 to 50 milligrams per day, are generally considered safe. However, it is absolutely critical to avoid taking very high doses unsupervised for long periods, for example, more than 200 milligrams per day. Such high doses can cause severe nerve damage, known as sensory neuropathy, which can lead to numbness, tingling, difficulty walking, and loss of coordination, and may not be reversible. Always consult your physician before considering high-dose B6 supplements. Subsection 3C Vitamin B9 Folic acid. Our third key vitamin is vitamin B9, which we encounter in two main forms. It exists naturally in foods as folate and as folic acid, which is the more stable synthetic form used in supplements and fortified foods. The primary active form in our bodies is called tetrahydrofolate, or THF. THF derivatives are absolutely essential coenzymes involved in a process called 1-carbon metabolism. This means they help transfer single carbon units in crucial biochemical reactions needed for several vital functions. One primary function is the synthesis of DNA and RNA, our genetic material. Folate provides the carbon building blocks needed to make purines and pyrimidines, the fundamental components of DNA and RNA. Because of this role in DNA synthesis, folate is incredibly important for any tissues in our body where cells are dividing rapidly. This includes the bone marrow, where blood cells are constantly being produced, the lining of our intestines, and of course, during fetal development in pregnancy. Folate is also involved in amino acid metabolism. A key reaction here, which we've mentioned in relation to B6 and will mention again with B12, is the conversion of homocysteine back into the essential amino acid methionine. Folate is a required partner in this process. How does this translate to kidney health? Firstly, by participating in homocysteine metabolism, folate helps keep levels of this toxic amino acid in check. Since folate deficiency is a major cause of high homocysteine, ensuring adequate folate intake, often supplemented along with B6 and B12, helps normalize homocysteine levels, which may indirectly reduce the associated cardiovascular risk. Secondly, folate is crucial for preventing a specific type of anemia called megaloblastic anemia. When folate is deficient, DNA synthesis is disrupted in the rapidly dividing red blood cell precursors in the bone marrow. This results in the production of abnormally large, immature red blood cells. Preventing this type of anemia is important for managing the overall burden of anemia commonly seen in CKD patients. Thirdly, beyond its role via homocysteine, some evidence suggests that folate might directly benefit the health of our blood vessels by improving endothelial function, the function of the cells lining the inside of blood vessels. It might do this by enhancing the production of nitric oxide, a molecule that helps blood vessels relax and protects them from damage. What's the scientific support? The effectiveness of folic acid supplementation in lowering homocysteine levels is very well established. Some large analyses of studies, particularly those conducted in places before widespread mandatory folic acid fortification of food, like a major trial in China, suggest that folic acid supplementation might reduce the risk of having a first stroke, especially in people with high blood pressure. However, its impact on other types of cardiovascular events or directly on slowing kidney function decline in diverse CKD populations still needs more robust evidence from specifically designed trials. The role of folate in treating megaloblastic anemia caused by its deficiency is, however, undisputed. Why are CKD patients at risk for folate deficiency? Those on dialysis lose significant amounts of this water-soluble vitamin during treatment. Dietary restrictions, particularly limiting certain fruits and vegetables high in potassium, which can also be good sources of folate, might also contribute. Additionally, alcoholism, conditions causing malabsorption, and certain medications like methotrexate or some anti-seizure drugs can interfere with folate status. Where can we get folate naturally? Excellent sources include dark leafy green vegetables like spinach, kale, and broccoli, as well as asparagus, legumes beans, lentils, liver, and avocado. In many countries, folic acid is added to enrich flour, bread, pasta, and breakfast cereals. Checking food labels is helpful. Now, a critical warning regarding folic acid supplementation. Giving extra folic acid, often in doses of 1 to 5 milligrams per day, is standard practice for dialysis patients to prevent deficiency caused by treatment losses. However, there is one extremely important precaution: vitamin B12 status must always be assessed before starting and monitored during high-dose folic acid supplementation. The reason is that high doses of folic acid can fix the anemia caused by B12 deficiency, but they do not address or prevent the potentially irreversible neurological damage that B12 deficiency can cause. By correcting the anemia, the high folate can essentially mask the underlying B12 deficiency, leading to dangerous delays in diagnosing and treating serious neurological problems. So, checking B12 levels is mandatory in this situation. Also, some people have common genetic variations that affect how they process folic acid. They might theoretically benefit more from the already active form, L-methylfolate, but using this requires specific medical advice and indication. Subsection 3D Vitamin B12's cobalamin. Our fourth vital nutrient is vitamin B12, also known as cobalamin. This is a large, complex water-soluble vitamin unique for containing the mineral cobalt. It's synthesized only by microorganisms, meaning we must obtain it from our diet or supplements. Absorbing B12 is also a complex process, requiring a substance called intrinsic factor, which is produced by cells in our stomach lining, for it to be taken up properly in the last part of our small intestine, the ileum. In humans, vitamin B12 is essential as a coenzyme for just two known, but critically important enzymatic reactions. The first is for the enzyme methionine synthase. This enzyme works together with folate to convert homocysteine back into the essential amino acid methionine. Vitamin B12, in the form of methylcobalamin, is required for this reaction to occur. The second reaction involves the enzyme methylmalonyl CoA mutase. This enzyme converts a substance called L-methylmalonyl-CoA into succinyl-CoA, which is an important step in the metabolism of certain amino acids and fatty acids. This reaction requires B12 in the form of adenosylcobalamin. When B12 is deficient, this reaction is blocked, leading to a buildup of L-methylmalonyl-CoA and its precursor, methylmalonic acid or MMA. Elevated MMA levels in the blood or urine are a very sensitive indicator that there's a B12 deficiency occurring at the cellular level. How does vitamin B12 protect us, especially in the context of kidney health? Its most critical role, arguably, outside of blood formation, is in preserving neurological health. B12 is absolutely vital for the synthesis and maintenance of the myelin sheath. This is the fatty, insulating layer that surrounds our nerve fibers. Much like insulation around an electrical wire, it allows nerve signals to travel quickly and efficiently. Prolonged B12 deficiency causes damage to this myelin sheath, a process called demyelination. This leads to a wide range of potentially devastating and often irreversible neurological and psychiatric problems. These can include peripheral neuropathy, often starting as numbness, tingling, or weakness in the hands and feet, balance problems and difficulty walking, gait ataxia, cognitive impairment, such as memory loss, confusion, or even dementia, like symptoms, mood changes like depression, irritability, or psychosis, and in severe cases, a condition called subacute combined degeneration of the spinal cord. In patients with chronic kidney disease, these neurological symptoms can sometimes overlap with or be mistaken for nerve damage caused by the buildup of uremic toxins, so uremic neuropathy. This makes assessing B12 status absolutely crucial to ensure correct diagnosis and treatment. Vitamin B12 is also essential for hematopoiesis, or blood cell formation. Working alongside folate, it's required for the proper synthesis of DNA during the maturation of red blood cells in the bone marrow. Deficiency leads to megaloblastic anemia, characterized by those large, immature red cells, just like folate deficiency. And thirdly, B12 contributes to homocysteine metabolism via that methionine synthase reaction, working synergistically with folate and vitamin B6 to help keep homocysteine levels under control. What's the scientific evidence linking B12 deficiency to these issues? The connection between severe B12 deficiency and megaloblastic anemia and specific neurological syndromes is firmly established through decades of clinical experience and research. Population studies consistently show that B12 deficiency, including milder or subclinical forms often detected by elevated MMA or homocysteine levels, is surprisingly common, especially in older adults, affecting perhaps 5% to over 15% of this group. It's also prevalent among patients with CKD. Key risk factors driving this high prevalence include age, related atrophic gastritis, which impairs absorption, and the widespread, often long-term, use of two common classes of medications: metformin, used for diabetes, and acid-suppressing drugs like proton pump inhibitors, PPIs, and H2 blockers, used for heartburn and ulcers. Metformin appears to interfere directly with B12 absorption in the ileum, while reduced stomach acid from PPI's H2 blockers impairs the initial step of releasing B12 from the proteins in our food. What are the main causes of B12 deficiency? In the elderly, the leading cause is malabsorption resulting from atrophic gastritis or the lack of intrinsic factor, a condition called pernicious anemia. As mentioned, long-term use of metformin and acid-suppressing drugs are major contributors. Because B12 is found almost exclusively in animal-derived foods, strict vegan or vegetarian diets, if not appropriately supplemented, inevitably lead to deficiency over time. Surgical removal of parts of the stomach or small intestine, such as after gastrectomy or bariatric surgery, or diseases affecting the ileum like Crohn's disease or celiac disease, also cause significant malabsorption. Where do we get vitamin B12 naturally? It's found only in foods of animal origin. Good sources include meat, especially organ meats like liver and kidney, poultry, fish and shellfish, clams, oysters, and mussels are particularly rich sources. Eggs, milk, and dairy products also contain B12. Some plant-based foods, like nutritional yeast or certain breakfast cereals and plant milks, may be fortified with B12, so it's important to check labels if relying on these sources. Now, the warning regarding vitamin B12. Screening for deficiency is generally recommended for older adults, anyone experiencing potentially related symptoms, neurological or unexplained anemia, long-term users of metformin or PPI's H2 blockers, vegans and vegetarians, and patients with known CKD or gastrointestinal conditions that affect absorption. The initial test is usually a serum B12 level, but this test can sometimes be misleading, particularly if results fall in the lower end of the normal range. Measuring levels of MMA and possibly homocysteine often provides a more accurate picture of whether there's a functional B12 deficiency occurring within the body's cells. Treatment involves supplementation. This can be done either with high-dose oral B12s, typically 1,000 to 2,000 micrograms daily, usually as cyanocobalamin, or through intramuscular injections. It's often 1,000 micrograms of cyanocobalamin or hydroxycobalamin, given more frequently at first, then usually monthly for maintenance. High-dose oral therapy is often effective even if someone lacks intrinsic factor, because a small amount can still be absorbed through passive diffusion. Injections are generally preferred if there are significant neurological symptoms or known severe malabsorption issues. Vitamin B12 is considered extremely safe, with virtually no risk of toxicity even at very high doses. However, the diagnosis of deficiency and the decision on the best treatment plan, including the route, dose, and duration, should always be made by a physician to ensure it's appropriate for the individual specific situation. Section 3.E, Vitamin K2's menaquinone. Finally, we come to our fifth vitamin, vitamin K2, also known as menaquinone. This one might be less familiar to some, but emerging research highlights its critical importance, particularly in relation to kidney and cardiovascular health. Vitamin K is actually a group of fat-soluble vitamins. We often hear about vitamin K1's filtration, which is abundant in leafy green vegetables like spinach and kale. K1's primary and well-known role is in blood coagulation, activating the proteins needed for our blood to clot properly, mostly occurring in the liver. Vitamin K2, however, represents a different series of compounds designated MKNs like MK4, MK7, MK9, where refers to the length of a side chain. K2 is found mainly in certain fermented foods and is also produced to some extent by beneficial bacteria residing in our gut. While K1 primarily works in the liver for clotting, vitamin K2 is increasingly recognized for its crucial roles outside the liver, specifically in regulating how calcium is handled in our bones and, perhaps most importantly, in our blood vessels. How does vitamin K work? Both K1 and K2 act as essential helpers, or cofactors, for an enzyme called gamma-glutamyl carboxylase, or GGCX. This enzyme performs a vital modification on certain specific proteins. It adds a chemical group called a carboxyl group to particular amino acid residues, glutamic acid, within these proteins. This process, called gamma carboxylation, essentially activates these proteins, giving them the ability to bind to calcium ions and perform their specific biological functions. These activated proteins are often called Gla proteins. Now, how does vitamin K2 protect us in the context of kidney disease? Its most striking role relates to preventing vascular calcification. As we discussed earlier, patients with CKD, especially those on dialysis, suffer from widespread and rapidly progressing calcification of their arteries. This deposition of calcium makes blood vessels stiff, raises blood pressure, damages heart valves, and is a leading cause of the extremely high rates of heart disease and death seen in this population. Vitamin K2 is absolutely essential for activating a specific Gla protein called matrix Gla protein, or MGP. MGP is produced by the smooth muscle cells within our blood vessel walls, and it's one of the most potent inhibitors of soft tissue calcification known in the human body. When MGP is properly activated through carboxylations, which requires vitamin K2, it binds to tiny calcium phosphate crystals that start to form in the vessel wall and actively prevents them from growing and hardening the artery. However, if there is a deficiency of vitamin K, particularly K2, which seems more involved in vascular health, MGP remains in an inactive, undercarboxylated state, as often measured as dP/OCMGP. This inactive MGP cannot perform its protective function. The vessel wall loses this critical defense mechanism, allowing calcium to readily deposit and accumulate, leading to progressive vascular calcification. Vitamin K2 also plays an important role in promoting bone health. It's required to carboxylate another key Gla protein called osteocalcin. Osteocalcin is produced by osteoblasts, the cells responsible for building new bone. Activated carboxylated, osteocalcin helps to incorporate calcium into the bone matrix, specifically the hydroxyapatite crystals, promoting proper bone mineralization and maintaining bone strength. This is particularly relevant for CKD patients who often suffer from complex bone diseases, renal osteodystrophy. In essence, vitamin K2 helps to intelligently direct calcium, guiding it towards the skeleton where it's needed for strength, and keeping it away from blood vessels and other soft tissues where its deposition causes significant harm. What scientific evidence supports these roles for K2? Large observational studies, like the well-known Rotterdam study conducted in the Netherlands, have found that people who consume higher amounts of vitamin K2 in their diet, especially the longer chain forms like MK7, MK8, and MK9 found in foods like certain cheeses and natto, tend to have less calcification in their coronary arteries, a lower risk of developing coronary heart disease, and lower overall mortality rates. When researchers look specifically at patients with CKD and those on dialysis, studies consistently find markedly elevated levels of that inactive MGP, a CMGP, indicating a widespread functional vitamin K deficiency in this group. Crucially, these high levels of inactive MGP are strong, independent predictors of how much vascular calcification a patient has, and they are powerful predictors of both cardiovascular death and death from any cause in this population. Encouragingly, several randomized controlled trials have investigated the effects of supplementing CKD or dialysis patients with vitamin K2, usually in the form of MK7. Studies like the VITEC-C trial and the IPK-HD study have shown promising results. They consistently demonstrate that K2 supplementation significantly reduces the levels of inactive MGP/DP/CMGP, suggesting that the supplemented K2 is being used to properly activate MGP, thereby enhancing the body's natural defense against calcification. Some smaller studies have even hinted that K2 supplementation might slow down the actual progression of calcium buildup in coronary arteries. However, larger and longer-term trials are still needed to definitively confirm whether taking vitamin K2 supplements actually leads to fewer heart attacks, strokes, or deaths in people with kidney disease. Why might vitamin K2 deficiency be common, or why might the need for it be increased in CKD? Typical Western diets are often quite low in vitamin K2, especially the highly bioactive MK7 form. Patients with CKD might further restrict foods that are relatively rich in K2, such as certain aged cheeses, due to concerns about their phosphorus or sodium content. Prolonged use of broad-spectrum antibiotics could potentially disrupt the gut bacteria that normally synthesize some K2 for us. Most importantly, the profound disturbances in calcium and phosphorus metabolism, along with the active process of vascular calcification already occurring in CKD, likely create a significantly increased demand for vitamin K2. The body needs more K2 to try and activate enough MGP to fight off the relentless calcification process. Where do we find vitamin K2 naturally? By far, the richest food source of the MK7 form is natto, a traditional Japanese food made from fermented soybeans. Certain aged cheeses, like Gouda, Brie, and Edam, contain moderate amounts of MK7 and other longer-chain menachinones. MK4, a shorter-chain form, is found in smaller amounts in some animal products, particularly goose livers, foie gras, egg yolks, butter, and meat from grass-fed animals. Now, a critical warning concerning vitamin K2 supplementation. Giving extra vitamin K2, particularly the MK7 form often studied at doses ranging from about 100 to 360 micrograms per day, represents a very exciting and promising area of research for potentially preventing or slowing down vascular calcification in CKD patients. However, it is not yet a standard, routine recommendation found in clinical guidelines, and initiating supplementation absolutely requires consultation with a nephrologist or a doctor knowledgeable in this area. The decision should be highly individualized, considering the patient's degree of calcification, overall cardiovascular risk, bone health status, and other factors. The single most critical point of caution is the potential interaction with the commonly used anticoagulant medication warfarin, also known by brand names like Coumadin. Warfarin works precisely by inhibiting the vitamin K cycle in the liver, which reduces the activation of vitamin K-dependent clotting factors, thereby thinning the blood. However, it also inhibits the activation of other vitamin K-dependent proteins like MGP and osteocalcin. Therefore, patients taking warfarin must maintain a very consistent intake of all forms of vitamin K, both K1 from greens and K2 from other sources or supplements in their diet. Starting, stopping, or changing the dose of a vitamin K2 supplement while on warfarin can significantly disrupt the anticoagulant effect, making the blood too thin or too thick, which can be dangerous. This requires extremely close monitoring of the INRs, the blood test used to measure warfarin's effect, and careful dose adjustments under strict medical supervision. It's important to note that the newer generation of direct oral anticoagulants, or DUXEs like rivaroxaban, apixaban, dabigatran, edoxaban, work through different mechanisms and do not have this direct interaction with vitamin K. Conclusion. Having explored these 5 key vitamins in detail, let's bring our discussion to a close by summarizing their roles and emphasizing the most important take-home messages. First, let's recap the vital contributions of these 5 essential nutrients for kidney health after 60. Vitamin D is crucial not just for strong bones, but for regulating the delicate balance of calcium, phosphorus, and parathyroid hormone, helping to control a common complication called secondary hyperparathyroidism. It also shows potential for reducing inflammation, slowing scarring, and protecting the cardiovascular system in the context of kidney disease. Vitamin B6 acts as a critical helper molecule, or coenzyme, in processing amino acids, particularly in controlling levels of toxic homocysteine. It might also help reduce the formation of harmful compounds called AGEs and supports healthy immune function. Vitamin B9's folate is indispensable for making DNA, enabling cell division and forming healthy red blood cells, thereby preventing a specific type of anemia. It works alongside B6 and B12 to manage homocysteine levels. Vitamin B12 is supremely important for maintaining the health of our nervous system by protecting the myelin sheath around nerves. It's also vital for blood cell formation and participates in controlling homocysteine. Deficiency is notably common among older adults and those using certain widely prescribed medications. And vitamin K2 is emerging as a key player in directing calcium within the body, guiding it towards bone where it's needed, and crucially, helping to prevent its dangerous buildup in blood vessel walls by activating the protective protein MGP. Now, while understanding the roles of these vitamins is important, it's absolutely critical to reiterate that vitamins are only one piece of a much larger puzzle. No single vitamin, or even a combination of them, can single-handedly guarantee kidney health. They function as supportive elements within a comprehensive, holistic strategy. This broader strategy must include several non-negotiable components. First and foremost is strict control of underlying medical conditions. This means diligently managing high blood pressure to meet the targets set by your doctor, often below 130/80 mmHg, and maintaining excellent blood sugar control if you have diabetes, typically aiming for an HbA1c below 7%. These two conditions are, by far, the leading causes of chronic kidney disease and the main drivers of its progression. Managing other heart disease risk factors like high cholesterol is also vital. Second is adhering to a scientifically sound, kidney-friendly diet. This isn't a one-size-fits-all approach. It requires an individualized plan, usually developed in consultation with a physician or a registered dietitian specializing in kidney disease. This plan will likely involve carefully managed amounts of protein, sodium, potassium, and phosphorus, tailored specifically to your stage of kidney disease. Emphasizing whole, unprocessed foods and limiting processed items is generally beneficial. Ensuring adequate hydration, based on your doctor's recommendation, as fluid needs can change with kidney function, is also key. Third involves embracing healthy lifestyle choices. This includes maintaining a healthy body weight, engaging in regular physical activity that's appropriate for your physical condition. Always best to discuss with your doctor first. Completely stopping smoking. Smoking is incredibly harmful to kidneys, and limiting alcohol consumption. And fourth is consciously avoiding substances known to harm the kidneys. This means being very cautious with medications, especially over-the-counter pain relievers like NSAIDs, ibuprofen, naproxen, using them only when absolutely necessary, at the lowest effective dose, and for the shortest possible time. It also means avoiding herbal remedies or supplements that haven't been proven safe and effective, especially those with unknown ingredients. Always make sure all your healthcare providers know about every single medication and supplement you are taking. This brings us to the golden warning, a message we cannot stress enough. The profound risks of unsupervised vitamin supplementation, self-prescribing vitamins, especially at high doses or using potent active forms, without proper medical evaluation, lab testing, and a doctor's specific recommendation, can be extremely dangerous. This is particularly true for anyone who already has kidney disease or is taking multiple other medications. The potential harms are significant. They include toxicity, especially with fat-soluble vitamins like A, D, E, and K, which can build up in the body when kidney function is impaired. Vitamin D toxicity causes high calcium levels. Vitamin A toxicity is especially hazardous in kidney failure. Even water-soluble vitamins like B6 can cause severe nerve damage if taken in excessive amounts. Supplementing inappropriately can also lead to nutrient imbalances, interfere with the absorption or function of other vital nutrients, and cause dangerous drug interactions, like the critical one between K2 and warfarin. Furthermore, taking high Dose folate can mask the signs of B12 deficiency, delaying treatment for neurological damage. And finally, spending money on unnecessary or potentially harmful supplements is wasteful and ineffective, diverting resources from care that is proven to help. So, what is the safe and effective path forward? It relies on two core principles: individualization and medical oversight. The only responsible approach involves these steps. First, have an open and honest dialogue with your doctor, your primary care physician, or ideally, a nephrologist if you have CKD. Discuss your diet, any symptoms you're experiencing, your concerns, and provide a complete list of all medications and supplements you take or are considering. Second, undergo a comprehensive assessment. Your doctor will order necessary tests to evaluate your kidney function. Check electrolyte levels like potassium, calcium, and phosphorus, assess for anemia, and potentially measure the levels of specific vitamins if deficiency is suspected, like vitamin D, B12, or folate along with PTH. Third, based on this complete picture, your clinical status, test results, stage of kidney disease, other health conditions, and current medications, your doctor will develop a personalized plan. This includes tailored nutritional advice and a specific decision about whether vitamin supplementation is needed, and if so, precisely which vitamin, what form, what dose, and for how long. And fourth, if supplementation is initiated, regular follow-up and monitoring are essential. This involves repeating relevant lab tests and clinical assessments to ensure the treatment is effective and safe, and to allow for any necessary adjustments to the plan over time. In closing, taking care of our kidney health as we age is an ongoing journey that demands proactivity, knowledge, and most importantly, a strong, collaborative partnership with our healthcare team. The 5 vitamins we've discussed today, vitamin D, B6, B9, B12, and K2, serve as powerful examples of how micronutrients can play vital roles in supporting kidney function and managing associated complications. However, they are not magic cures. Their true benefit and safety depend entirely on using them correctly. The right vitamin, for the right person, at the right dose, under the right medical supervision, and always viewed as just one component within a comprehensive strategy for overall health. The final, and perhaps most crucial, message is this: never compromise your health by treating or taking supplements based on hearsay, advertising, or incomplete information. Consider your doctor and registered dietitian as your trusted guides and partners on this journey. Be empowered to ask questions, seek reliable, evidence-based information, and work together to make informed decisions that will best protect the invaluable, life-sustaining function of your kidneys for years to come. Proactive, informed, and medically guided care is truly the key.